The first presentation, which is regarding lymphoma treatment with CAR T cells. And I will present some thoughts. I thought since it's already late, I'll probably focus a bit on a case report and start you off with the case, and then when I come back to some of the data that are related to this case, I will discuss what could have been done better or what could be new developments. And that's why we afterwards go into real-world experience and some evidence, and then talk a bit about possibilities to increase our efficacy in treatment. So here is the patient. It's a 50-year-old male patient with LBCL, which complicated the treatment for an underlying myeloproliferative disease. The patient had ET, so you're still in the right session. We're talking about lymphoma, okay? Patient was diagnosed with JAK2 positive ET at the age of 35. The initial treatment was done with pegylated interferon, but he developed severe psoriasis, including arthritis, and interferon had to be stopped. And then in 2019, he was started on ruxolitinib because of the side effects of the PEG interferon. About a year later, the patient was diagnosed with a diffuse large B-cell lymphoma. It was an anaplastic subtype, non-GCP, a double expressor score 2, strongly positive for MAM1, positive for B-cell markers, but negative for mutational analysis of P53. He had a mediastinal bulk and general lymphadenopathy, diffuse bone marrow infiltration with about 5% of lymphoma cells. And on the right side, you can see the PET-CT at this time, clinical stage 4 with a mediastinal bulk and pronounced avidity in multiple lymph nodes and in the right pleura. And you can appreciate that there are some osseous secondary lesions, and there was a suspected involvement of the left kidney. So the IPI was 4, and it was an advanced disease, obviously. And above you see the bone marrow with the infiltration. So quite extensive disease in this patient. For those of you who are not very familiar with this type of lymphomas, we have described this lymphoma entity a few years ago. So these lymphomas are usually already preceded by a B-cell clone that is found in the bone marrow when the myeloproliferative disease already exists. And once these patients are treated with a JAK2 inhibitor, for instance, then through immunosuppression, the B-cell lymphoma starts growing. These lymphomas are immunosuppressed type of lymphomas, so they are predominantly non-GCP or high-grade B-cell lymphomas, predominantly extranodal, including the bone marrow. The IPI is usually above 2. And these patients have a poor prognosis. So it's a rare entity, but of the first 6 patients which we described, 4 died within half a year of progression. And so I would say it's a high-risk LBCL, but the question is now, how do we treat this patient? We knew that these patients, 4 of these patients died, so what to do? We started with a classical RR-APOC and then had, for some complications, we had to switch to R-CHOP ×5 and 2 doses of rituximab. And at the end of this treatment, the patient indeed had a complete remission. But shortly after that, he had an early relapse and with a mediastinal para-aortal disease. And at that time point, since we knew that it was a high-risk lymphoma, we decided to give him a CAR T-cell therapy. And the CAR T-cell therapy in this case was axi-cell because he was a young person and we didn't have any other CAR T-cell at that time in our hands. It was given second line because what we did in between was that we bridged the patient with polatuzumab vedotin and rituximab. And he did achieve a second complete metabolic response and then received the CAR T-cell infusion in complete remission. Not many acute side effects, but the patient had repeated infections afterwards, herpes, RSV, bacterial pneumonia, a number of infections since he received the CARs. However, he is still in ongoing response. The bone marrow is cleared, as you can see on the right side. So if we look at this case, he is now 3 years after CAR T-cells. The lymphoma is in CR. He has circulating CARs measurable. His CD19 cells are not measurable. He needs Ig substitution. Regarding the myeloproliferative disease on the right side, you see that the platelets are still low. So the patient doesn't have to be treated for his MPN currently. And he also has a very low JAK2 burden, by the way. And no anti-MPN therapy is currently needed. So I hope we did the right thing. However, as I said, the problem is infections. So why do I show this case? I mean, it's a case that would never have been treated in any of the clinical trials because for SUMA-7, which would be the corresponding study, he would be ineligible for an autologous transplant for the control arm because he had an MPN. He had a comorbidity, again MPN, and we did give the CARs when he was in second CR. So, and then I will come back to some of these things. So what's the real-world experience? The next two slides have been given to me by Anna Soreda because she has oversight over the EBMT registry, and you will appreciate that most of these patients nowadays are real-world cases and not clinical study cases. So we have a great reservoir of data that we could access. And most of these patients, as you can see, 5,800 are diffuse large B-cell lymphomas in the EBMT registry. So we can actually tap into this data and gain some experience from real-world patients where about 1/3 to half of these patients would not fulfill the criteria. So here you see some of the trials that have been published. On the first 4 trials are real-world studies, in principle in second line or above, and you will appreciate that in the real world, all the data that came from the clinical studies have been recapitulated with high overall response rates, good CR rates, and in some real-world studies even better than in the clinical studies. But the 2 trials that would be pertinent to our case are the pilot and the Alicante trial, who were intended for patients who did not qualify for autologous stem cell transplant. In these two trials, you see that the overall response rate is 80%, the CR rates between 50 and 70%, with good progression-free survival of around 40 to 50% after 1 year. So I think it's fair to say that our patient, for instance, would fall into this Alicante population, while he is a bit younger than most of these patients. And these are the curves for this Alicante trial, and you see that the curves after 12 months regarding event-free survival, progression-free survival, overall survival are excellent, and this is recapitulated. The other trial is the trial with Lysocell, and it shows in essence the same data. So if you look at this population for the PFS, you see that the CR patients have not reached the median in PFS. PR patients do, of course, a bit worse. The current follow-up is 24 months. And if you look on the right side, the 12-month rate for PFS is 46% overall and 78% for those in remission. So that would be our patient. He is in response 78%, but with the axi-cel. As I said, we had the axi-cel at that time point, but our main problem was infections with this patient, which is not unexpected in an immunosuppressed patient. There's one thing that the new data with liso-cel show when you compare them head to head. Axi-cel, of course, is a great effective CAR. That when you use the liso-cel, the number of patients experiencing a CRS is lower, the number of ICANS is lower, but for our patient, what's important is that, for instance, the number of infections expressed by CMV, viremia, etc., is less. I think this, in the future, when this will be available, it's not available in every country in Europe. This may add to our armamentarium. What you can also appreciate is that the liso-cel ANC is in median higher than the axi-cel ANC, and that, of course, may also be part of the experience that these patients have less infections. So when we go back to the CAR T-cell cycle, what are the other things that could be optimized in regard to our patients? So, of course, pre-apheresis and patient selection data are important. I thought we could ask the patients, and Natasha Bolaños gave me this data from the Lymphoma Coalition. What do the patients think? What is important to improve? It's registries, it's access to clinical trials, it's increased CAR T-cell production capacity, access to emergency rooms, communication between local hospitals and the CAR team. I think that's important. Accessibility to patients through their primary hematologist, information, and improved physical and mental health during the CAR T-cell preparation. When we talk about access, of course, this can be improved. Economics plays an important part. This is a paper that we were part of this action that was published by our colleagues from Rotterdam, who estimated what the costs of CAR in the following years were. So the estimate was done in 2018 and 19, and now you can see where we at 2024 in terms of costs of care, incremental costs, CAR T-cells. So this is a burden. This may impede access, and it does in some countries, as we know. Information of doctors and patients. Adherence to guidelines is an important thing to consider, and of course there are country and healthcare specific effects. This is data from my own country, from Austria, which we collected in 2021, 2 years after the CARs were approved for routine in Austria. And on the left side, you could see the population, eligible population that we calculated. It's around 90 patients in Austria per year at that time for the third-line indication. And in fact, only 19 of these 89 in 2021 received the CARs. And that was probably mainly because the patient just were not sent to the CAR T-cell centers. This has considerably changed now. Most of the patients will really get to the centers, but it's an area of concern. And then, of course, screening and identifying patients is always important. We had an algorithm in our country to begin with where we selected patients, and the idea here was really that we selected patients where we had a good pretest probability that they would respond to CAR-Ts. So the selection criteria were quite strict. The median overall survival and the 6 months and 12 months overall survivals were very good. You see that 12 months OS was 75. However, we probably did not treat some patients who could have profited from this treatment. So I think in recent years, one part of the optimization is that we've really relaxed these rules, and more people will get CARs. On the other hand, this is my center's data. You can see the patients who were treated before 2020, and that's the blue lower curve. But we've learned to treat the patients better, and the overall survival increased considerably, probably through the use of more of other products, through the use of more tocilizumab, etc. So we know how to treat the side effects, but there is a considerable center learning effect. Now you could say, well, those are the guys from Vienna who initially didn't know how to treat the patients with CARs, but there is good English British data, and the British data did something very nice. They differentiated between an early era, like we did before, and the late era, with, of course, many more patients. And you can see that in era 1, the 12-month PFS was 31.6%, and in era 2, after some adjustments, the patients are now profiting much better from this treatment. So I think this really shows that we've learned how to treat patients. And then what we've also learned is that we should keep an eye on the quality of the T cells before we treat the patients. These are data from our own center where we showed that a low frequency of differentiated T cells predicts for a favorable response to CAR T cell therapy. That means at the time of apheresis. And what we saw is that patients who had a complete response at months 3 or 6 had much lower rates of these differentiated T cells in their peripheral blood, so it could be used as a predictor. What about bridging? Yes, I think that's part of this success, because I would like to acknowledge the fact that even with the axi-cell patients, we do more bridging than in the initial studies. There is 50% approximately response to bridging, and most centers will now use polatuzumab, bendamustine, rituximab, and that really has changed the way we think about bridging, because these patients do respond. My favorite topic is lymphodepletion, and we've investigated the current data that are around for this topic in a recent article in Frontiers in Immunology. Lymphodepletion does not only kill the lymphocytes, but it will have some effects on the tumor and on the tumor environment and on the composition of the T cell compartment. So I think it's really important to keep an eye on that, and there are some changes that we can make. And this is a nice paper that was published by our colleagues from the Sloan Kettering, where they showed that there is actually an optimal dose of fludarabine, for instance, that you could give, which is based on a population PK. So not everybody should in principle get the same dose. And there's an optimal dose. If you give more fludarabine, then patients will have toxicity. If you give less fludarabine, patients will not respond as well. There are new data on bendamustine, not only for T-cell, where bendamustine is part of the approval, but there are also data in smaller studies for axi-cell, 2 types of data for axi-cell, and there are even data for the myeloma patients. And what, particularly for the lymphomas, they have in common is that you see the infection rate with bendamustine is considerably decreased with T-cell, with axi-cell in 2 studies. So I think if I would treat our patient today, I would probably give him bendamustine. He was immunosuppressed to begin with, so that may be something that could be done. Finally, post-CAR, I think we have good management rules through the EBMT, for instance, and here is the CRS example. What we've definitely learned is that we consider tocilizumab as soon as the patient gets the first signs of CRS. So we don't wait until the CRS is 2 or 3 in grade. And the other thing, of course, is that once the patient has reached a grade 2 CRS, the communication between the departments, of course, is better, and ICU will be alerted, etc. So we will treat it more aggressively. These are data regarding infectious side effects, non-relapse mortality. And the more patients we cure, the more we will have to deal with this problem. And if you just concentrate on this dark red curve here, you see that this is increasing over time. And it's mainly infections. The dark red curve are infections. So that's the main problem over time. And that's why, of course, also for our patients, we have some concerns and why we do substitute them. This is also related to neutropenia, by the way, and that's, I think, that one of the achievements that optimize our management of CAR T-cell patients is certainly the hematotox score, which can predict who the patients will be, who will have a problem with ANC or also with severe bacterial infections, and I think this should be part of the workup. Finally, once the patient has a relapse, of course, we've heard at this meeting a lot about bispecific antibodies. Bispecifics have a very successful rate of rescuing relapsed patients. They are both active, both of these products that have been tested so far are active in CAR T-cell patients up to 60% approximately, and with good CR rates, and the CAR T-cells actually expand when we give these bispecifics, so we can rescue these patients. So I will come to an end here. So I hope that I have shown you that many patients can be treated now with CAR T-cells who would never have been considered in the clinical studies for CAR T-cell treatment, that we relax the criteria who should be treated, that we learn how to improve the outcomes of these patients, and that, of course, there is room for improvement at every step of the CAR T-cell cycle. And with that, I'd like to thank my colleagues who were involved in this study. So we go back to the first question. The question was about ICANS with lysocell. And I would like to ask you to vote again on this lysocell question. And by the way, if you have questions, you could think about asking me right now and also sending them in. Yeah, so the answer is D. So lysocell, apart from lowering the rate of CRS and lowering the rate of infections, also has a low rate of ICANS. And so I think we would certainly agree on that. There's one more question. That's a bit more tricky. The best practice EBMT recommendations, a patient reaches grade 2 CRS. What do we do? Next. Yeah, so in fact, there are two things. If you look at the scheme, then you should inform your ICU right away. However, of course, I would have done the same thing that you do, give the TOSI first and then alarm the ICU. But they are, let's say, happening at the same time. The question was intended to, let's say, sharpen this question a bit. And with that, I'm done with my presentation. If there are acute questions, then feel free to ask them. I'll walk over there. Thank you very much. So, do we have...
Can I ask a quick
Yeah,
question?
sure.
So if you're giving bendamustine-based bridging,
Yeah.
and then your LD chemo is the same dosing, do you consider that extra LD chemo and maybe higher infection rates, or do you see better responses when you do that?
Yeah, there are two answers. So number one, we had patients when we give our polar benda as bridging, they end up with having no T cells at all before we go to lymphodepletion. So there are some patients in this population where we don't even give lymphodepletion. And for the others, we just do it the same way, and we've not seen increased rate of infection. It's still only 2 cycles if you, in most patients. In this patient, there were 3 cycles of bridging, but we didn't see it. Yeah.
Interesting.
Thank you very much.